Hi, all. Thank you all for joining today's live Aspen Health for All conversation. These conversations are part of a larger effort housed at aspenhealthforall.org that is amplifying the important work being done by leaders and innovators all over the world to address the disparities that have been amplified by COVID-19. Our aim is to focus on health equity and connect a range of experts working on the front lines of health around the world as we all pivot to respond to the challenges of COVID-19. We are in search of a common solutions and shared insights. And as the US reckons with the legacy of racial injustice and the continued systemic oppression of Black lives, we want to take this moment to say that we will not tolerate violence and hatred against Black communities. Our global community stands tall with local leaders, collaborators, healers, and fellows who long been beacons in this movement and whose voices and work are critical to reshaping a healthy, equitable future for all. Today, the Aspen Global Innovators Group is excited to host a conversation with Fatima Hassan, a human rights lawyer and social justice activist and founder of Health Justice Initiative, and Priti Krishtel, a veteran of the Global Access to Medicines movement and co-founder of IMAC. We're honored that Dr. Gavin Yamey will moderate today's session. Dr. Yamey is the director of the Center for Policy Impact in Global Health based in Duke Global Health Institute. The center is an innovative policy lab that addresses the critical challenges in financing and delivering global health. As a reminder, please feel free to ask questions throughout the session using the Q&A box. With that, let's get started. Over to you, Dr. Yamey.
Hello, everyone. I am really delighted and honored to be moderating this webinar today. Before I briefly introduce our two amazing speakers, let me quickly set the scene. The only way in which we're going to end this COVID-19 pandemic, what's called herd immunity, and we need the whole world, not just one country, to have that herd immunity. Herd immunity is when a high enough percentage of the population, a so-called herd, is immune to the disease. They've got antibodies. Most scientists think we're going to need to have 70% of the world with antibodies. We thought maybe we could get there if enough people are infected by the virus, recover, and have antibodies. That is not going to happen. For example, Spain was very hard hit by this pandemic, and in fact, only 5% of the population has antibodies. So we're going to have to get a vaccine to end the pandemic. The good news is that the current vaccine development efforts are probably the fastest in history. Just 63 days after China shared the genetic code of SARS-CoV-2, the virus that causes COVID-19, the first trial began in Seattle. 2 days later, the second trial in China. And yesterday, I looked on the World Health Organization website. There are 163 vaccine candidates being developed. 23 are in human trials. 3 of those are in advanced trials, so-called phase 3 trials. And South Africa and Brazil are participating in one of those, the Oxford University AstraZeneca trial. Very few of those are going to make it all the way through. About 7% will make it all the way through. But even if we develop a safe, effective vaccine, there is no guarantee right now that everyone is actually going to get it. We're going to need large volumes. It has to be distributed worldwide. We have to go the last mile. We have to allocate it ethically, fairly, at a reasonable price. And we've already seen rich countries try and monopolize the supply. For today's conversation, we're going to assume that a safe and effective vaccine is made available, but how are we going to ensure equitable access? That's the question that we're going to discuss with two remarkable experts, Priti Krishtel and Fatima Hassan. Priti Krishtel is a lawyer and veteran of the Global Access to Medicines movement. She was the co-founder of IMAC, a team of patent detectives who expose and challenge how the patent system fuels inequitable access to medicines. And with her, Fatima Hassan, a South African human rights lawyer and social justice activist who heads a newly established initiative called the Health Justice Initiative. In the HIV/AIDS field, Fatima worked as the legal representative of the Treatment Action Campaign at the AIDS Law Project. So welcome, Priti and Fatima. I'm going to moderate a discussion amongst us till around 11:20, and then I'm really looking forward to opening us up for questions. So, Priti, kick us off, if you will. When you look back at the past experiences of global vaccine access. When you look at those historical examples, are you confident that people worldwide will have access to COVID-19 vaccines?
The short answer is no, Gavin. Time and again, we've seen that people in low and middle income countries are left behind and denied access to vaccines. One example of this is HPV, human papillomavirus, which can lead to cervical cancer. When we started working on HPV vaccine access about 8 years ago, 250,000 women had died from cervical cancer that year in low and middle income countries. And the companies that made the vaccine, GSK and Merck, were charging nearly 10 times the cost of production in the poorest countries. And it was the price was a lot higher for middle income countries. So it was well beyond what most countries could pay. Not surprisingly, most countries didn't introduce the vaccine. And at the same time, a similar story was playing out for pneumonia, which kills almost 1 million children every year. The PCV vaccine is the one used to protect children against pneumonia. So with both HPV and PCV, high prices and minimal competition are one reason that low and middle income countries are being left behind. Now, about 8 years ago, we investigated this, and we found that both of these vaccines had dozens of patents being filed on them in key manufacturing countries like Brazil, India, China. And then we knew from conversations with manufacturers in those countries that the patents, or the patent walls actually, where dozens of patents were being filed, were serving as a barrier. Suppliers don't really want to risk getting sued, so they get delayed in entering the market. And I should add here that patents obviously are not the only issue. Without sharing of technology and know-how and data, we just haven't reached a sufficient number of suppliers to meet the global demand for either HPV or PCV access. So when I think about this in the context of COVID, I remember these examples because 5 years ago, more than 50 countries went to the WHO, the World Health Assembly, asking for solutions and support due to the unaffordability of these vaccines. And now it's 2020, and by next year, they're saying 5.5 million girls in the poorest countries are at risk of missing their HPV vaccination because there isn't enough supply. And a similar story is there for PCV. Many middle-income countries are still unable to introduce it due to the cost. So when we think about COVID and we think about the fact that we need everyone everywhere to get it, and we need to unlock the world's full manufacturing capacity, I definitely think it's going to be a challenge. And when we see the first prices that are being announced, the only public prices that we really have to date are saying about $10 to $13 per dose. And now if that's true, that's more than twice what we're seeing being paid for the most expensive vaccine in the poorest countries.
Yes.
So I guess just to articulate one final challenge, and I think we're all aware of this because of the news, we are living in a moment of deepening nationalism, which makes it more likely that wealthier countries are going to be hoarding than they have in the past. We're still not seeing binding access commitments amongst governments worldwide. But we are seeing governments entering into advanced bilateral deals with manufacturers to stockpile future vaccines. So I think in this moment, the crisis can be a turning point, but only if we have enough public pressure to create a new normal for global access. We need to unlock and share knowledge on a global scale that is unprecedented. And in doing so, I think we can not only change the situation for equitable access to the COVID vaccine, but we'll be able to affect all these other situations like HPV or pneumonia worldwide and vaccinate everyone everywhere.
Thanks, Priti. That's very interesting that potentially, if we can get it right on COVID-19 vaccine, be some spillover effects for other vaccines. That's very interesting. I wanted to bring you in a bit about barriers like high prices, minimal competition, patents, the possibility of hoarding of vaccines, vaccine nationalism as it's called. Isn't it true, though, that we've got a framework now, an intellectual property framework, an international trade framework, where countries can essentially override some of these barriers, like patent barriers, in a public health emergency? Fatima, can't those, provisions be used?
So, I mean, theoretically, yes. In practice, not very often. So certainly there's a framework that permits flexibilities for a public health emergency crisis. And we certainly saw that when 9/11 happened and people needed to have stocks of anthrax, for example. But there's been a handful of countries, I think about 8, that have indicated a political willingness to override patents in this time of COVID-19. There's certainly developing countries that have not said that. They haven't been unequivocal about it. The African Union, which is actually chaired by the South African president at the moment, met in June. There's a beautiful statement with lovely words about equity and universal health coverage and proper pricing, but not once do they mention that one of the tools that they will use will be to actually break patents, to issue compulsory licenses, to take the necessary price controls and the available regulatory tools that they have. So I think that goes to the issue of the system of power that we're operating in globally. But that's a long way of saying yes, theoretically, the TRIPS flexibilities do allow that, but whether countries will actually, in effect, given the power that the pharmaceutical industry currently yields in a number of these vaccine trials, as well as in the development of vaccines and in other treatments, remains to be seen. And that's why I think we need quite a vigilant civil society and quite a vigilant independent media to be able to shine a spotlight on these very issues.
Thanks, that's interesting. So it's true, there's a lot of, there's a million op-eds out there from world leaders saying this has to be free for all and it has to be a global public good. But at the end of the day, you don't see much talk about actual price controls and actual breaking of patents. The other issue, Priti, is that many of these vaccines, of course, are being publicly funded, right? These companies are getting taxpayer money to develop these vaccines. Are governments then saying, look, as a condition of getting funding from us, you need to then commit to making the vaccine affordable, available, accessible? Is that sort of conditionality happening?
So as far as we know, there's very little transparency, but as far as we know, governments have put almost no conditions on drug makers that would ensure accessibility and affordability. I'll say that taxpayers are the real angel investors when it comes to finding a vaccine for COVID-19. Here in the US, for example, the office that oversees biomedical R&D is called BARDA, and they have invested more than $4 billion of public money in COVID research on 6 vaccines. And this morning, there was actually some breaking news that that number actually is closer to 6 billion. So on the first 5 vaccines that they have invested in, it appears that the government hasn't put any conditions on that money. So while industry isn't assuming all of the risk, it's a pretty safe bet to say they're going to get all of the reward. And in my view, there's 3 changes that we need to see happen going forward. First, we need transparency. So if taxpayers are going to bankroll this vaccine development, we need a full public accounting of how much industry is putting in vis-a-vis government. We also need a full reporting of the results of that investment, including the technology, the IP, and the know-how, because without that, it's just a subsidy. Secondly, we need access conditionalities on this kind of investment at this level. If we're putting in $4 to $6 billion as taxpayers, then every single person should be getting affordable or free access to that vaccine. And then third, I think, speaking long-term, we really need patent reform. Because if we as taxpayers are co-investors in your invention, then we as the public should be co-owners of that invention. We also know from our global experience, like I was saying with PCV and HPV, that patent walls or thickets, when so many patents are being filed to deter competition, these do serve as a barrier for manufacturers to enter the market in the long run. And quite frankly, in a moment like this, especially, it's just not okay. We need as many manufacturers as possible so we can save as many lives as possible.
Thanks. In fact, I think one of the first statements that got me very nervous was when the Health and Human Services Secretary, Alex Azar, was asked about this issue, that taxpayers are essentially funding this. Shouldn't you guarantee price controls and low prices? And he sort of said, no, we have to leave it to the market. It's very un-American. And honestly, alarm bells rung. And I thought, if that's the thinking, we are in some trouble here. Fatima, talking about public funding, I mentioned at the beginning that the Oxford University AstraZeneca trial, that's publicly funded. The UK government is funding it. And I see that South Africa is participating. Can you tell us more, Fatima, about the South Africa trial? And does that mean your country is more likely to benefit because it's participating? Is that the sort of the deal?
So, I think that's a great question. And, Priti mentioned earlier that there's very little transparency in respect of the bilateral agreements that the different vaccine developers and governments are entering into. So on the one hand, South Africans were really excited and proud to be participating and to be offering that solidarity to offer participants to be part of a clinical trial, which I think is important because it really will help Africa and it really will help the region. But we are none the wiser as to the terms and conditions of the agreement between AstraZeneca, Oxford University, the South African government, and Wits University, which is actually the lead, the clinical team that's leading the trial in South Africa. So they've taken participants, they've had volunteers who've joined last week. And it's similar to the obstacles we faced in the HIV/AIDS days was when we probed and when we asked questions of these pharmaceutical companies and of our government, there is very little transparency. And I think this is the issue that concerns us. This is just one of a potential of 140, potential vaccine candidates. We don't know how many more vaccine trials we'll be participating in, with how many different companies. But certainly, I think the public in South Africa, but also I think the rest of Africa has a right to know what are the terms and conditions. And I'd like to probe that a bit more by saying, who's in charge? Is it Oxford University? Is it AstraZeneca? Is it the South African government? Is it the Brazilian government who's also participating in the trial? So there's many unanswered questions. I think what that does is it puts healthcare practitioners and the volunteer subjects in a very difficult situation, because on the one hand, you want to advance science, you want to contribute to innovation, but on the other hand, there's so many unanswered questions. And I think you and Priti mentioned earlier, the notion of vaccine nationalism, the notion of bilaterals that are happening in the north, the idea of hoarding, the idea of buying up supplies in advance. What does that mean for South Africa? What does that mean for Botswana, Lesotho, Zimbabwe, countries that don't have the infrastructure that we have to participate in trials, countries that don't have a necessarily highly skilled functional government that can try and negotiate issues around patent barriers. So the lack of transparency is very concerning in the middle of a pandemic that is making inequality even worse. I mean, yesterday a study was released in South Africa that said since the beginning of lockdown and as a result of COVID, the number of families that have gone hungry has actually doubled in our country. Yet we one of those countries that can participate in a vaccine trial, right? So if you look at the scale of inequality and the scale of poverty in a country, you can imagine what those discussions are around the table with those very big multinational companies that are driving these vaccine trials and research.
Yeah, I mean, I am not an IP lawyer, but I work with someone, I know someone, they keep writing to me saying, have you seen any of these contracts? If you've seen them, can you share them? We're desperate to see what's actually in writing. And it's a question, I think there isn't transparency about what's in them. I'm going to move to, I see there's some questions. Before we take questions, let me just ask each of you, what do you think people watching this webinar could do? What action could they take? I want to make sure we get to that before the Q&A to help with this global access question. What are some of those actions, Priti?
So I've been very inspired by, there's a campaign called hashtag Free the Vaccine Pledge. And it was started by students and creatives through the universities Allied for Essential Medicines and the Center for Artistic Activism. It's grown into a global campaign right now, and I would definitely recommend following it.
Excellent. Free the vaccine. Fatima.
So, I mean, I agree, free the vaccine, but free the vaccine not just for the North. We need to free the vaccine for the South as well. And we don't want a repeat of what happened with the HIV/AIDS epidemic, where we were the last to receive life-saving treatment, which caused so much premature suffering and death. So if the HIV/AIDS epidemic is anything to go by, we certainly don't want a repeat of that. And so we have to ensure that the South is given a seat at the table. If we're not involved in the negotiations at a multilateral level right now, then decisions are being taken for us and about us, where representation is just regarded very superficially, but where we don't have a real say in whether people living in Africa are actually going to be able to access the vaccine, that it's affordable and that's available to them at the same time that it's available to the rest of the world.
We've got 3 questions. I'm going to just take them in order in which they arrived. The first from David Bryden. Priti, could you discuss what efforts are underway in the US Congress to condition public money on affordability? Is Congress trying to make sure the vaccine's affordable here in the US?
I think it's a moving conversation. I think there are members of Congress who are trying to place some type of emphasis on access restrictions and conditionalities. There's also a strong movement in Congress, or a number of voices, I think, who are underscoring the fact, just like Gavin said, that we do need to leave this to the free market, and that we don't. A lot of this conversation happens under the framework of innovation, that innovation shouldn't be hindered at any cost. So I think some of the tensions we're going to see arise in the coming months are going to be ideological. If we talk about access or affordability, are we actually hindering innovation? Obviously, you probably can guess my answer. The answer is no. But there are a lot of people who think that we need this just unfettered landscape to allow industry and universities to research without placing that burden on them to think about how people actually get it. And that's what our movement for access to medicines is actually trying to raise and make visible, that we do need to start seeing bills that are going to start being introduced that actually address this head on.
There's a question from Bailey Knight. Bailey, I'm actually going to adapt your question slightly and broaden it. And it's really about allocation. Let's just assume that, I don't know, early 2022 or maybe late 2021, we've got a couple of billion doses, but we need to give everybody 2. Actually, it's a 2-dose schedule, which means we can only vaccinate 1/8 of the world. Who should get it? And who's at risk of not getting it? How do we ensure that those initial doses, which by definition are going to be limited in supply, are distributed fairly? It's an easy question. Fatima, your thoughts on that? Assuming initial supply is limited, how do we think about allocation?
So I mean, that's such a difficult question to answer, because on the one hand, we are against vaccine nationalism when the US or the UK practices that. And on the other hand, as activists in local contexts and in local countries with high populations of people living with HIV or people living with TB or people who are at risk, or migrant populations or women who are pregnant who need the vaccine, or people who are over 65, etc. So I think that the debate in the next few months, or the negotiation in the next few months, is going to have to be around the very horrible word or the very horrible process of rationing. How do you ration? The concern, of course, is that majority of supplies, like what happened with PPE, like what is happening with testing kits, is actually going to be reserved for the global north. And I think the challenge is we have the evidence, we know what's going to happen. How do you prevent that? How do you stop that? How do you create a global movement of activists when in a time of COVID to try and shine a light on that, to try and ensure transparency and try and ensure fairness and equity in a world where we've never really had fairness and equity before, if you just look at the provision on a whole range of diseases. So it's a difficult question to answer, and the danger, I think, in saying what the ideal outcome should be is that we could fall in the trap of those very countries that we are accusing of being a vaccine nationalist, in a vaccine nationalist mode.
And Priti, let's just assume that, okay, after those initial couple of billion, we ramp up and we do have more. Are there still communities that you are worried might be left behind?
Yeah, so I just want us to acknowledge up front that we're talking about how to allocate scarce supply because we haven't tackled the root issues that leave these decisions on production volumes totally up to the discretion of industry. I saw a few questions in the Q&As around, well, what do we think about COVAX and CEPI and these wonderful international multilateral groups who are really trying to advance vaccine access. And this is what I would say is that we're still talking about allocating scarce supply because we're not going far enough on the root issues. We want to dance around intellectual property and pretend that it doesn't exist. We don't want to compel industry to do anything. And I think we need, frankly, support from investors and people who really have power in the world of industry and universities who have the ability to influence those decisions. Because there is a world that's possible in the future where we have legal frameworks that mandate competition and tech transfer, or where we see increased voluntary action in that regard, where governments are actually diversifying and increasing their R&D capacity and local manufacturing. Right now, I would say under this old system that we're in, we are seeing, the WHO or national governments putting out their initial thoughts on allocation. And we're hearing about healthcare workers and elderly and people with comorbidities. And that's important, but it's not enough. In making these allocation recommendations, we are not seeing explicit recognition and commitment around refugees, around people in prison, around people living in really crowded lower income settings. And so I think I would just say that we have to be really careful now about how we decide, obviously, in these allocation discussions, who gets what, but we can't brush the systemic issues under the rug. We have to start bringing these things around technology transfer, local production, intellectual property rights. These conversations have to be happening in the room.
I think that, Fatima, you have the last word, and then I'm going to pass back to Tsiona and the Aspen folks.
No, I mean, I couldn't agree more. The AU issued a statement related to Africa and identified the need to develop a vaccine roadmap. And one of the pillars of that roadmap, they've said, is ramping up manufacturing capacity. It's been 3 weeks since that meeting. We don't know what they mean by ramping up manufacturing capacity in Africa. And so I think the issue is that we're seeing a lot of nice words and beautiful statements, but we're not seeing the action plans that will actually get to the point where, as Priti correctly says, where we won't have to ration, where we can manufacture it ourselves, where we can distribute it ourselves, where we can supply it ourselves at an affordable level so that entire populations at risk, who are at risk immediately and who may be at risk later, would have access to it. So, I also think that, I think that in a lot of respects, governments are acting very slowly and they're relying too much on what I call the benevolence or the charity of the industry. And that is not going to save lives. And I think we saw that with HIV/AIDS, relying on the benevolence of the pharmaceutical or vaccine manufacturing industry is not going to actually save lives and create an equitable system for sharing.
Thank you so much for such a great conversation. Back to our hosts.
Yes, thank you so much. Thank you, Priti. Thank you, Fatima. Thank you, Dr. Yamey. We hope you all will consider taking action today to support the important work of these leaders. We've dropped links in the chat function, but please go to aspenhealthforall.org to find their websites, to learn more about Aspen Health for All in tomorrow's newsletter. And please be sure to stay in touch, sign up for our future conversation, and please use the hashtag Aspen Health for All on social media. Thank you.